Because I think that one of the biggest areas that we're excited about, Meryl, is immunotherapy. And she has a trial that's currently going on that's very specific to a certain kind of breast cancer and triple-negative breast cancer, which I would say, I'll come back to this, one of my biggest disappointments will be 5 years from now is if we don't do better in some of these harder to treat breast cancers. And so I'd like her to talk about what she's doing along those lines to make it a better world for those cases.
Thank you. I agree with Dr. Port about our vision for the next 5 years is to really help better treat the difficult to treat cancers, the more aggressive cancers that have a higher likelihood of resisting our current standard of care treatments, specifically from a medical oncology perspective, chemotherapy. We know that chemotherapy is very effective on the different regimens that we discuss, but there are many patients who are not cured or put in lifelong remission from our standard of care treatments. Immunotherapy, as Dr. Port mentioned, is a new armament tool that we hope to be able to leverage to better prepare the patient to fight their own cancers by revving up the good immune responses and dampening the poor or bad immune responses. And to combine that with our current regimens of chemotherapy to better fight, for example, triple-negative breast cancer, which has seen the most success with immunotherapy. Dr. Port is correct. We're also hoping to leverage other targeted therapies. For example, BRCA-related cancers. We have a trial that's unique to us in New York City that aims to look at the effectiveness of PARP inhibitors, which aim to really hit the Achilles heel of BRCA-related cancers by damaging their DNA and preventing them from surviving a DNA damage event. We hope that one day for BRCA-related cancers, PARP inhibitors and a similar class of agents may eventually replace chemotherapy for the treatment of BRCA-related cancers. Again, we are hoping to use these various tools, immunotherapy, targeted therapies, to better tailor and individualize patient cancer treatment.
I think that one of the things I want you all to leave here, there's nobody that gets a breast cancer diagnosis that doesn't think it is one of the worst days of their life. It's the worst thing that's happened to them. And the question of mortality always comes up. But let me be crystal clear that with a diagnosis of breast cancer, there is so much room for optimism in 2019. And for most women, we are taking care of breast cancer now, for most cases, where we can literally say to them, you have a 90+% chance of survival. There are some cases where we're telling them, you have a 98% chance of survival, okay? 99%. This is success, okay? Between 2000 and 2010, due to the development of a few key drugs, the death rate from breast cancer each year went down 2%. That meant that if you were diagnosed after 2010, you had a 20% higher likelihood of survival than if you were diagnosed before 2000. This is all real progress. Exactly the question you asked, Meryl, which I couldn't have, closed out with a better phrase, is what we need to do is all of that is the groundwork we've laid to give the vast majority of people the optimism they need to go forward. They will live long, healthy, productive, full lives. What we need to work on is the outliers that continue to be the reason why we get up every morning and come to work and sit in the lab and reconstruct patients and look for better ways of imaging and look for better ways to treat people. So those are the things that we are working on, and you will hear more and more each year from us because we are on it.